Good morning, good afternoon, and good evening, everyone. Welcome to the ICAP Grand Rounds webinar, Bridging the Gap Using Mathematical Models to Monitor the HIV Epidemic. This is a special 90-minute Grand Round, so if you can stay the full time, that would be great because we'll have discussion at the end. I'm Shannon Farley, the Director of Surveys at ICAP, and I'm very pleased to have you all here today. Data from the population-based HIV impact assessment, or the PHIAS surveys, which are nationally representative surveys used to capture the state of the HIV epidemic in the most affected countries, are used for a number of purposes. Firstly, by national HIV programs in each country where the data was collected, as well as by US government PEPFAR teams, including by UNAIDS as part of spectrum modeling. Here at ICAP, we were interested in learning a bit more about how these PHIA data are used in the model, so we reached out to Mary Mahy, and in response, our Grand Rounds today will be presented by a stellar group of colleagues involved in the development of the UNAIDS estimates. And we will learn about the use and feature of the AIDS impact model AIM, part of the spectrum system, including the in-country experience with the estimates, and how models like these can be used to triangulate available data to provide the best estimates. As a reminder, if you have questions for the panelists, please use the Q&A box. The webinar and the recording and the slides will be posted on the ICAP website. I've got the URL right there. So let me introduce the panelists. We have 5 of them today. First off, we'll be hearing from Mary Mahy, the Director for the Data for Impact Practice at the Joint United Nations Program on HIV and AIDS, UNAIDS in Geneva, Switzerland. She compiles and analyzes data on HIV epidemiology and the HIV response in countries. And I would like to particularly thank Mary for her help in organizing and planning this panel. Then we'll hear from John Stover, the Vice President and Director of Modeling and Analysis at Avenir Health. Dr. Stover's work focuses on policy development, strategic planning, resource allocation, and monitoring and evaluation, primarily in the field of HIV, AIDS, and family planning. He works with the UNAIDS reference group on estimates, modeling, and projections to develop models for HIV estimates and projections. Our next presenter will be Jeffrey Eaton. He's a reader in epidemiology, demography, and applied statistics at Imperial College London. Dr. Eaton co-chairs the UNAIDS reference group on estimates, modeling, and projections, which is a scientific advisory group that advises UNAIDS and partner organizations on the data, methods, and tools used to quantify the HIV epidemic. His research involves developing new mathematical models, statistical methods, and surveillance tools to characterize HIV epidemic trends, transmission dynamics, and the demographic impact of HIV in Africa. Then we will get the country perspective from Wilfred Karungi, who is a principal medical epidemiologist and leads strategic information at the Uganda Ministry of Health AIDS Control Program. Dr. Karungi works on epidemiological surveillance, population and facility surveys, strategic planning and monitoring and evaluation, and research on HIV and other infectious diseases. And to tie it all together, we will hear from Anna Burstein, an assistant professor in the Department of Population Health at NYU School of Medicine. Dr. Burstein specializes in modeling to inform disease control and prevention and serves on the steering committee of the TB Modeling and Analysis Consortium. So without further delay, I will hand it over to Mary, our first presenter.
Thanks, Shannon. And let me just start by thanking ICAP for inviting me to come to this presentation. I think so much of what we do around the HIV estimates is about partnership. And so for me, it was really critical that it be a presentation done by a group of us. And so really happy to have, first and foremost, Wilfred on the call, because that country work is critical for making the estimates a success. They do the hard work of putting the models together. And then John and Jeff for their contribution in terms of the modeling programs as well as the thinking forward. And then of course, Anna coming in with, as you mentioned, Shannon, the, pulling it together from a broader perspective. We don't work in a vacuum with these estimates and the modeling we do for UNAIDS. We work very much looking at what else is going on in the HIV modeling world. And Anna is also part of the HIV modeling consortium, which is an important part of what we do. So I'm going to go ahead and share my screen and take you through this presentation. Share. There we go. So I just want to take you through first the main point of my presentation is a bit of a starting place. We'll come in later with a lot more details about the model, but the first question is, why do we need models and how will it help public health? Second question is really about how do we make sure this process happens on an annual basis to create these estimates? And finally, what I was asked from ICAP specifically is to look at how we use the population-based survey data in the models. So if we think back and, over time, starting from the early 1980s until today, what data has been available for HIV in understanding the epidemic at the country level? From early kind of mid-1990s or so, we started asking countries to collect prevalence from their antenatal clinics, sentinel surveillance sites. Those tended to be high burden sites, and a handful of them around the country. And those data were collected over time. We then started getting data in the 2000s on the number of people on treatment, which was important for understanding at the country level where they were at with providing drugs to make sure people were staying alive and living with HIV. We then started in the early 2000s to have household surveys, and those household surveys collected data on behavior, or it wasn't the start of household surveys, but household surveys with HIV seroprevalence data in them, but they also had behaviors in them. And so that data was also coming in to inform what we knew about a country in terms of their HIV epidemic. However, that was only feasible in countries with prevalence over about 2%. Otherwise, the sample size was required to be too big. And so we also started collecting prevalence from key populations, the integrated biobehavioral surveillance surveys. In those surveys collected data not only on prevalence, but also on behaviors. And so that helped us understand what was happening in countries that were not generalized, but as well as in generalized epidemic countries. Over time, then, countries started doing case surveillance, pulling together information on how many people were reported to be living with HIV, and also that mortality. However, that was primarily in high-income countries, and we still, to this day, don't have good data in low and middle-income countries on that case surveillance or mortality data. Then in about 2014, countries stopped collecting that sentinel surveillance data that had gone on for so long, and we moved to using the routine data that was produced as pregnant women went into their antenatal clinics and were being tested for HIV. So we started using that routine data. We also, around the same time, had ICAP and others producing surveys that had more biomarkers. So biomarkers on things like HIV recency and on viral load suppression that helped our models even further. So this is the context we were working in over time. None of these on their own provided us the information we needed to know to understand what was happening in an HIV epidemic. So we turned to models, and so these have been going on for quite a while now. But what do models do for us in terms of public health? First of all, they provide that information that's not apparent from a single data source. And combining that information allows us to have a coherent set of data of all of the information that's available in a country to understand their epidemic. It also allows us, as I've showed down here in the graphic, to explore scenarios. What are kind of the programmatic pieces that could happen that we could change in a country in order to get better impact of our HIV response? It lets us stimulate questions and also figure out how to impact, or how policies and programs will impact that epidemiology. One thing that's really important with the estimates as well is that it will capture the underlying population. So as the change in our fertility rates or change in migration rates affect our countries, we can put that information into the model and see how that will impact our HIV prevalence and our incidence and our mortality. Finally, we can measure those indicators that are really difficult to measure directly. So incidence in AIDS-related deaths, items that are, or indicators that are just not easily collected, can be modeled, and that helps us with our understanding of the epidemic. There's also some additional benefits that I want to touch on. So from UNAIDS perspective, it allows us to ask countries to produce and submit this data to UNAIDS so that we can have a set of data that's globally recognized, but also comparable. It measures progress towards the national, but also global targets that are developed. And for example, in this graph down here, I'm showing what are changes in new infections between 2010 and 2021. We can compile the data from these different regions and see on a regional level, where are we going? Who's doing well and who's not doing well? What's happening, for example, in Eastern Europe and Central Asia, that we're still seeing increases in new HIV infections, as opposed to Eastern and Southern Africa, where we're seeing this nice decline. So that allows us to produce, or allows countries to produce data that's consistent. So when they're applying for Global Fund grants or for setting targets for PEPFAR, they're comparing similar results between different countries. It also allows us to report on the Sustainable Development Goal indicator 3.3.1, which is on the HIV incidence. And so that comparability over time is really important for UNAIDS, but also for countries to make sure that they're achieving their targets and reporting in a comparable way. So just a brief overview, and as I mentioned, John Stover will go through the actual model in more detail. But when we think about the estimates, first of all, we produce these estimates for about 170 countries every year. That number varies slightly by year, depending on which data is available to us. Only about 130 countries actually publish their estimates. There are a number of high-income countries that we actually don't publish because we haven't come to a complete conclusion with the country as to what their estimates is, or they don't have their data that's finalized at the time of publication, and so we don't publish those. But it provides, these estimates provide historical estimates from 1970, when there was no HIV being measured, until 2022, usually the last year. So this year in 2023, we'll produce estimates through 2022. And we provide estimates on new HIV infections, AIDS deaths, people living with HIV, a number of other indicators as well, that are used for countries to understand their epidemic. Those models incorporate different data depending on which country they're in and which data are available within a country. So for example, prevalence from antenatal clinics, prevalence from key population surveys, prevalence from household surveys are included, but also program data on number of people reached with treatment or number of pregnant women reached with PMT-CT services. Some of our more high-end countries, well, not high-end, high-income countries, also have data on case surveillance, where they have good, solid case surveillance data available, and mortality data. In a few countries, there's about 39 countries in sub-Saharan Africa where we have household surveys and robust data. We do produce district level estimates, going down to understand what's going on at lower levels of the HIV response. This graph here, I'm just going to talk about briefly, shows some of what I was describing before, whereas from about 1990 on, we had this ANC sentinel surveillance data in green. Then about 2014, we shifted over to the pink data points, and that's the routine antenatal clinic data. We then have household surveys, these red diamonds here, and we fit a curve to those data in order to understand what's happening with HIV incidence. So this shows you how all of those different data sources come together to provide us with our best understanding of what's happening with the HIV epidemic. Just another piece on the process for developing the estimates. We do this, as I mentioned, with partnership with countries. So country teams actually create these estimates. By relying on these country teams, it really ensures that there's ownership of one harmonized set of data that describes the epidemiology in a country. And so, for example, you're not pulling treatment coverage from a program and HIV prevalence from a survey and AIDS mortality from your case surveillance. This makes sure that all of those data are coming from a consistent source to make sure that they're harmonized across each other. It also guarantees the country knowledge is is captured in these estimates. We want to make sure that people who know that data best are the ones who are putting that into the model and are thinking through what the implications of those data are. We also want to make sure that the collaboration that's built when countries produce these estimates makes sure that all of the folks in the country who are producing data are using the same estimates over time. Another point is just to say we have workshops that are held every 2 years to make sure that the countries know the changes that have happened to the models and to support them with any questions they might have about putting data into the models. We ask for facilitators from a number of our partners, and that makes sure that they at the global level also buy into those data and understand how they're produced and recognize their benefits and their limitations. And finally, we ask for sign off on those estimates from ministers of health and senior managers at the national AIDS councils in order to make sure that they also trust those data. In the right here, I'm just showing a graph of how, for example, West and Central African countries can measure their testing and treatment cascade, and allows that comparability across countries with this data set. Just a point here on the estimates. Some people ask, well, why do they change from year to year? And there's two real reasons for this. And one is that the models change slightly from year to year as we get better science on what's happening in the HIV epidemic, or we get more information about how best to model the epidemic. There's usually very few models. This year, there will be a change in the number of new infections or incidence rates, because we're more closely aligning them with viral load suppression that we're seeing among people on ART. So it's tied to that information on what we call the third 90, or the viral load suppression of those people on treatment. But also what happens is that the countries update their models. And so, for example, if a FIA has recently taken place, or another household survey has taken place, the prevalence data or other information from that survey will be put into the model that could have impact on prevalence, and thus the incidence curves produced in the model. So here's a graph from a publication that's a few years old, but it helps explain a little bit about how we create trends over time. That red line is the estimates currently on how many people are living with HIV. The blue line is what we thought were the number of people living with HIV in 1997. So it's what UNAIDS published. As you can see, in 2003, 2004, we were overestimating the number of people living with HIV quite significantly. In about 2007, we started putting the household survey data into the software, and that helped us tremendously with correcting what's happened over time. And you can see we've stayed fairly consistent to our current trends since then. A lot of what happened too in that 2007 was we got a household survey from India, and that was critical for understanding what was happening in India and their HIV epidemic. So very important change. Now, just thinking about what's happened since this paper was written, we have more data going in from the FIAs, particularly on incidence and ART coverage. And so that data is going also into the model to help us understand PLHAV as well as incidence and mortality. And just recently, as I mentioned before, we're using the viral suppression to inform incidence. So that leaves us with about 38.4 million people living with HIV. Just a couple more slides here on how we use that population-based survey data. When we look at the data that are going into the model, specifically we look at HIV prevalence, and that's been used for a long time. And then since the FIAs have started collecting the incidence data, we've included that in the curve fitting as well as the ART coverage to help understand and kind of triangulate the data that we have on programmatic number of people on treatment as well as the population prevalence. And Jeff will come back to this in his presentation as well, some of the challenges that we're seeing there. But those survey data are also used for validation. So here's a graph showing a combination of data between 2022 and 2023, looking at it's the year of the survey that I'm comparing here. So where we have data from 2017, Cote d'Ivoire, this is spectrum data for the year HIV incidence for the year 2017. And what we're showing here is just the comparability. The lines here are the confidence intervals that come with the household surveys and compared to the spectrum estimates in the blue. A few outliers here with Namibia, but for the most part, they're fairly consistent. That being said, it's important to note that incidence does go into the fit here, but that it's primarily driven by the HIV prevalence data from the household surveys. One of our biggest challenges that we've had, and we've worked closely with ICAP on this, is looking at how we estimate the number of children living with HIV. It's a very difficult measure to make because there's fewer and fewer children living with HIV as PMTCT programs succeed and children are graduating into the adult age group. But one of the things we've done in the past is compare prevalence from those household surveys. Most of them are a bit older because they're not being collected more recently. And looking at our spectrum in the light orange, for the most part, we see they're fairly close. But we use that survey data to really try to validate what the models are suggesting. Last piece to mention here is about how the models are being used in our district level estimates that I mentioned. So for countries to understand where to prioritize their HIV response, they need to have lower level data than just the national data. So we take the household survey data and we include that in our model as well as program data to distribute the national prevalence across districts. So in this example, we're showing the data of where the high prevalence is in Ethiopia, yeah, and then we put in the additional program data to try to understand what's happening. The real challenge, though, is to understand where those data are good quality and where there might be problematic data. So we ask countries to use this tool in the NAOMI model, I should say. And it looks at for example, here, ANC prevalence over time to see where there's something changing dramatically that might not be correct. So it's looking at the district level. It allows the country to look at different indicators or different metrics and try to see where there might be problem with that data at the district level so that it gets corrected there. And then when it gets to the national level, it will hopefully be all smooth and corrected and correct. So key messages. I think everyone agrees, and there's many other public health interventions that also use models. They're really necessary to understand progress towards targets, but also to raise and answer questions that we might have. They do change annually. The UNAIDS estimates change annually as the assumptions are updated, but also as the countries add in new data. These biometrics from the more recent survey have been increasingly valuable to complement the models and provide additional data that's needed to understand the epidemic. We also know that those model results are only as reliable as the input data. And so really pushing countries to improve that data has been an important effort from UNAIDS. Mostly, I also want to stress finally, I want to stress that the process is almost as important as the results, making sure that countries have that harmonized data and that they fully have bought into that information is critical for that data use and for improving the quality. Thank you.
Thanks, Mary. So this is John Stover now, and I'm going to talk a little bit about some of the methods of data and assumptions behind the estimates. So first on the structure of the model, you can see the big overview here. The 4 boxes on the left in purple are the data inputs that we use. And then the green in the center is the models, and then the gray is the outputs. So we use several different types of data. One is demographic data. I'll talk a little bit more about that in a minute, but we need the population by age and sex over time. The second data type is program statistics. So this is data that the program collects on number of people on treatment, the number of women receiving prevention of mother-to-child transmission prophylaxis, number of people testing, et cetera. The third type is epidemic patterns. And this is the one of the 4 types that's not generally country specific. But this is using information from cohort studies and special studies to help us understand some of the basic natural history of the epidemic, how people progress through CD4 count categories, mortality on and off ART, et cetera. And then the final data type here is surveillance, survey, and routine testing data that help us understand prevalence and trends over time. So the first step really is for countries to assemble these data. The epidemic pattern data are assembled by the UNAIDS reference group. The other three types are all assembled by the country teams. The next step then is to use these data to estimate prevalence and incidence trends. So we use the data, as Mary showed, whatever data is available. So one of the models is called EPP, Epidemic Projection Package, and that uses the routine testing at ANC, the surveillance data, and survey data to estimate, to fit curves to prevalence, and from that derive an incidence trend. But countries that don't have surveys and may not have good general population surveillance can use other models. So we have another one called C-Saver, which uses case reports, numbers of new infections, number of AIDS deaths, to also estimate prevalence and incidence trends. And there's another AIDS epidemic model, which is used in 13 countries using behavioral data and key population data to estimate incidence and prevalence trends in some of the Asian countries. So regardless of which model is used, the output of that is a trend in incidence among the population 15 to 49 over time. Those data then go into these additional models, first to the adult model, that's used to calculate the number of people living with HIV, new infections, et cetera, and followed over time. Then there's a model that calculates mother-to-child transmission of HIV, and then a model that follows children living with HIV. And then finally, all these calculations produce the key outputs that we see here. So a little bit more detail about the adult and the child model. So as I mentioned earlier, we start with the demographic inputs. For most countries, they use the detailed demographic estimates and projections prepared by the UN Population Division under their World Population Prospects program. And a few countries customize that using their own data or their own national estimates. Those population data feed into just about all aspects of the model. So I mentioned the incidence trend here. So here we're using surveillance data, routine testing data, information about key population sizes. And this is one place where the surveys, the FIAs and the DHS are critical because countries that have these surveys, it allows us to fix the level of prevalence. We can pick up the trend from the surveillance and routine testing data, but this helps us get the level right. And in some countries now that have had up to 6 surveys, it also helps us understand the trend. So that information then coming out of those incidence models is incidence among the adult population 15 to 49. We need to split that into incidence by age and sex. So all age groups from 15 all the way 15 plus by 5-year age group, and then also by sex and by year. So we have various methods to do that, but the 2 prominent ones are to survey prevalence data. So find the incidence, distribution of incidence by age that allows us to match prevalence by age that's found in the surveys, or lacking those surveys, fit it to information about ART coverage by age. That information then goes into the PL-HIV model, where we track people living with HIV by age, sex, CD4 count, and ART status. And I'll talk a little bit more about that in the next couple slides. And then finally, that leads us to estimates of mortality to people living with HIV, both AIDS-related and non-AIDS related. And here we use other information to help define that. The child model is similar. However, it starts not by fitting incidence curves to surveillance data, but by calculating transmission rates from mother to children based on the model estimates of HIV prevalence among pregnant women, pregnancy rates among people living with HIV, program data about the use of ARV prophylaxis, and then study information about transmission rates given type of prophylaxis. Once we've estimated the number of new child infections, then we can put that into the PLHIV model and track children by age, sex, CD4 count category, CD4 categories, and ART status, and then from that follow on to calculating mortality. So here's an example of how we split the incidence among all adults 15 to 49 into age groups. And what we're seeing here is the point estimates with their confidence intervals come from a survey. In this case, in this country, it's the 2017 FIA. And they're showing us the prevalence by sex, females are blue, males are red, by 5-year age group. And then the solid lines are Spectrum's estimate of prevalence by those age groups in the year 2017. So we use this information to validate or to fit, depending on the country, to ensure that the model can replicate the patterns that we find in the surveys. And we do this by generating a set of incident rate ratios and testing them against the prevalence data until we get a good fit. And once we've done that, then we have some confidence that we're replicating the key dynamics, because we're able to replicate a pattern of prevalence by age here in 2017 with a model that starts in 1970 and projects all the way forward. The adult model looks something like this. Once we've estimated the number of new infections in a particular age and sex group, they get assigned to a CD4 category. You can see we've got 7 categories of adults by CD4 count, and people could start any of these categories, but we've used program data to estimate the distribution of new infections. And then people living with HIV are followed over time as they could die. So that's the new parameters here. Then the death could be from AIDS or from a non-AIDS cause. They could progress. So CD4 counts generally decline over time, and that's what these lambda parameters define. How rapidly do people progress through these categories? And then there's some rate at which people can initiate ART, and we track their category at the time of initiation of ART, and that produces a different set of mortality rates, much lower, of course, for those on ART. And then we can accumulate the mortality by each CD4 count on and off ART to estimate total AIDS deaths. We have a similar model for children that tracks different categories, but in a similar way. So to make this model work, we have to understand what are these mortality rates by CD4 count, what are the progression rates by CD4 count. So to understand survival or mortality, we use data from cohort studies. So number of European cohorts and also the Sub-Saharan Africa cohorts that have followed people over time. These are all historical studies now showing us progression of people living with HIV that did not get on ART or before they got on ART. So this is showing us the natural history of survival, and you can see it by age group. And then what we want to do is derive mortality and progression parameters that allow the model to replicate these patterns that we see from the cohorts. So here we're matching to the survival patterns over time, but we can also match to the CD4 count distribution of the population living with HIV at the time of a survey. So here you can see for a collection of different countries, the model estimate of the distribution of people living with HIV by CD4 count category in green, and then the dark brown is the FIA estimate. So that by being able to fit to these CD4 count distributions from the FIAs, it gives us, again, more confidence that we've derived a good set of natural history parameters. The other piece that we need is to know about mortality once people get on ART. And here we use data from the IDEA consortium, which pools data from treatment sites and then analyzes it to provide the information required by the models. So here you can see a pattern of mortality shown in the vertical axis by CD4 count at ART initiation, by duration of time on treatment, less than 6 months, 7 to 12 months, or greater than 12 months. And you can see the declining mortality pattern. Here we have a similar graph, but this is now showing it by age. And so we also have it by sex and by region. So this information helps inform us about mortality rates when people get on ART. Another key aspect of the calculations of mother-to-child transmission has to do with the fertility of HIV-positive women. Studies have shown us that their fertility is generally less than the fertility of HIV-negative women. And survey data can be analyzed to show us how the relative fertility of HIV-positive women changes with their CD4 counts. So at lower CD4 counts, their fertility is much lower. It also changes by age and whether or not women are on ART. So we use the surveys to figure out these patterns and then can apply these patterns to the country data on numbers of pregnant women to understand how many of them are HIV positive. So the model then produces these key outputs, that some that Mary described, people living with HIV, new infections, AIDS deaths. It also then produces the denominators that allow us to calculate ART coverage and PMTCT coverage to compare these against our targets. We calculate mother-to-child transmission rates and the full cascade, knowledge of status, viral suppression. And in countries that have good survey data, we can also take this down to the next level to do subnational estimates. So I want to end by focusing on some of the sort of higher level outputs that help us understand the progress we're making. So this is the dashboard that we have, where the chart on the upper left shows you the trajectory of new infections over time and compares it to the global goals of reduction 75% from 2010 to 2020 or 90% by 2030. And then the upper chart on the upper right shows the same thing for AIDS deaths, showing the trend compared to the targets. And then on the lower part of the graph, we have two indicators of epidemic transition that UNAIDS recommends. So one is the incidence mortality ratio. And when that comes down to the dashed line to 1, it means that the number of new HIV infections is equal to the number of deaths happening to people living with HIV. So the population living with HIV will no longer be increasing, and the country will be on a path towards epidemic control. And the one on the right is the ratio of incidence to prevalence, which is simply another indicator of how the country is doing in terms of being on a path towards epidemic control. So this allows us to look at the big picture. Mary showed you some treatment cascades. So for each country that has all this information, we can look at people living with HIV, the proportion that are on treatment, the proportion who know their status, the proportion that are on treatment, and the proportion that are virally suppressed. We can see how the country has progressed over time. We can see the gaps, and we can see what remains to be done. And then the final chart I'll show you here is on mother-to-child transmission. So that's always a controversial issue because everybody wants it to be as slow as possible, and sometimes the model estimates come out that it's actually quite high. So this chart shows you how the model arrives at its estimate. So in this particular example, it's estimating that the mother-to-child transmission rate is about a little above 11%. The components of this bar show you where that's coming from. So the very bottom component that's really small here is women that were already on ART at the time they became pregnant and remain on treatment. So they have a very low transmission rate and contribute practically nothing to the overall transmission. And then we can see women that's started on ART, but or already on ART, but dropped off before delivery, or women that got started on ART during the current pregnancy and those that dropped off. We also have a component for women who didn't receive any prophylaxis because they didn't go to ANC or they didn't get tested. And also this very dark component is the component that's contributed by incident infections that happen after a woman's already tested negative, but she becomes infected later during pregnancy. That has a high transmission. And the second part of the bar, these segments are during the breastfeeding period. So countries that have long periods of breastfeeding also have significant risk of transmission. So this helps us both understand how Spectrum is producing this estimate, but also can provide some program guidance about where we need to focus in order to bring this transmission rate down. So that's a very quick overview of what's going on in the Spectrum software. There's lots of other information for those of you who are interested in going into it in more detail. The Spectrum software is available freely from download from our Avenir Health website. It also has help files built into it that you can get a lot more information about it. And then there's UNAIDS has sponsored a series of methods papers over the years that provide all the details. And here's just a few of the references for you. Thank you very much.
Sorry, help if I unmute. My name is Jeff Eaton. I'm a reader in the MRC Center for Global Infectious Disease Analysis at Imperial College London. And I'm going to speak now about some of the future directions for the UNAIDS supported HIV estimation models. I also just want to note, it's wonderful to see so many familiar names and faces in the audience, and many people who have engaged in the estimates process and given feedback and developed the models. And so I want to acknowledge everyone in the room here today who's been a part of what we're going to see here. So first, I wanted to speak a bit about what guides changes to the HIV estimates models, or why the models change. Mary mentioned that the models evolve over time and change slightly year to year. And there's really three key reasons that the models change over time. The first are the models change in response to evolving epidemic dynamics. For example, when HIV incidents started to peak and decline in many countries, that required a new set of models to capture those data. As treatment has scaled up, that's required new models to accurately capture the impact of treatment on mortality and HIV incidence, and then across different types of epidemics. And as epidemics change types, it requires different types of models to capture that. The second reason that models change are innovations in data sources and HIV surveillance. As new data become available about the HIV epidemic, the models need to change to be able to incorporate the evidence from those data into the overall estimates. As Mary tracked, some of the very large changes that we've seen at certain points in time were directly responsive to new data sources that gave us better information than we had before about what was happening in the HIV epidemic in certain countries or globally. And the third reason that the models change is to respond to new programmatic and monitoring priorities. Principally, the purpose of the estimates process is to support HIV programs with information that they need to guide and monitor their programs. And so as strategies change and policies change, different information are needed out of the models. And so for the rest of the presentation, I'm going to talk about some of the recent changes and future directions for models. And you'll hopefully see examples of how these different changing epidemics, changing data, and changing priorities have interweaved to inform the changes in the models that have happened and will happen in the future. One main theme for changes in the models in recent years, and we anticipate going forward, is firstly integrating routine HIV service delivery for surveillance and estimates. This has been a major theme over the past 5 years, and as the service delivery data become more granular, this provides a great new opportunity to also understand the epidemic in a more detailed way. A second theme is increasing stratification to identify inequalities and monitor an equitable response amongst key and vulnerable populations. As we're all aware, the new global AIDS strategy to drive us towards ending AIDS as a public health threat by 2030 is really focused on ensuring that HIV programs are reaching all populations that are in need. And this is an example where the models need to keep up to be able to provide information about that. And a third theme is that our HIV surveillance priorities and strategies will need to and will transition as we strive for monitoring sustained epidemic control, and that's going to drive changes in the models. So first, one example of a large recent change to the models was driven by our program priorities towards being able to monitor progress towards the 90-90-90 targets. We all know back in 2013 or 2014, all countries in the world set targets to reach 90-90-90 by 2020. And the FIA surveys provided us new data that we never had before to assess at a point in time where we were at. For example, in Malawi, the FIA survey in 2015 and 2016 told us that around 77% of people living with HIV were diagnosed, 91% of those were on ART, and 91% of those were virally suppressed. But then what happened between 2015 and 2020? The number of people tested for HIV in Malawi continued to increase as they strive to attain the 90-90-90 targets. Around 150,000 people were diagnosed with HIV per year. And so we needed over time an ability to track what the implications of these programmatic efforts were towards where we were at in the 90-90-90 targets over time. And so in response to this, we created a new model that combined the household survey data on HIV testing history, for example, from FIA surveys and DHS surveys, with the HIV program data on the number of tests and the number of HIV diagnoses over time to say in each year what is tracking the cumulative progress to date towards the 90-90-90 targets. And so we were able to get out from that, similar to the other estimates that are shown, a nice smooth trend tracking the steady progress towards increasing awareness of HIV status and indeed treatment coverage and viral load suppression in Malawi and across countries in sub-Saharan Africa. This modeling, though, also through using mathematical models to synthesize and reconcile all of the various data sources, also gave much richer information about what was happening in the HIV testing and treatment programs. For example, through balancing the HIV incidence or the new infections with treatment coverage and diagnoses, we were able to deduce through mathematical modeling that around 60% of people who were being diagnosed with HIV in 2020 were re-diagnoses. So people who had been diagnosed before and for one reason or another being re-diagnosed. And I think that this, along with other evidence, has really helped drive changes in how people conceptualize the role of HIV testing services and pathways in and out of care that we now know so many people follow. Another key area where we've seen this important combination of combining household survey data, such as the recent FIA survey data with routine program data, are the district level HIV estimates that Mary talked about. Again, this was a high priority need for HIV programs as they sought to more granularly target programs towards districts that had high burden or high need. And so we developed a new model to produce district level estimates for HIV burden, treatment coverage and unmet need, and new HIV infections. And this is done through integrating, again, multiple data sources. So geolocated household survey data, the locations of survey clusters within districts, combined with facility level routine antenatal clinic HIV testing data and treatment program data. So for example, underlying these district level HIV results for 2020 and the 2022 UNAIDS HIV estimates are HIV test results from over 30 million pregnant women attending antenatal care facilities across the continent. And again, this model was there's a great deal of effort to develop new spatial modeling methods to combine all these data sources. But another key challenge was how to bring these quite computationally intensive statistical modeling tools and make them available to users through within the HIV estimates process and in the HIV estimates teams that Mary described. And so the model was implemented as a web-based tool, which users could upload their own data, interact with the data and visualize the data, and then produce and review model results. One of the things to be aware of is as the importance or the reliance on HIV program data has increased in the HIV estimates process, it also means that the accuracy or reliability of those data becomes that much more important for the robustness of the results that come out. And so this is just an example or a word of caution of what we're starting to see emerging from when we compare the most recent round of FIA surveys with ART program data across several countries. So we see in a few countries, the survey estimates for the number of people receiving treatment are almost exactly aligned with the ART program data reports for the number of people receiving treatment. But in several countries now, we're seeing a somewhat concerning pattern where the ART program data are around 7 to 15% higher than recent survey estimates. And especially as countries are now getting close to the 95 targets, a 7 to 10% error in our program data might have very large impacts on underestimating HIV treatment gaps or misrepresenting HIV incidence trends. And so again, this highlights the importance of robust survey data to continue to help us understand our program data and the importance of ensuring that these data sources align to understand holistically what's happening in the HIV epidemic. Next, I'm going to turn briefly to some of the priorities going forward. One key priority for the UNAIDS reference group over the past couple of years and the next couple of years are strengthening our ability to estimate new HIV infections and care cascades amongst across population groups. So I think many people will be very familiar with what UNAIDS publish annually for the distribution of new infections across key population groups. This is a standard and widely cited output from the UNAIDS reports, but it has some limitations. Firstly, it's only produced by global regions, not at country level. It's produced through an in-house UNAIDS in-house special analysis using heterogeneous data and methods and assumptions across countries and regions. And I think most importantly, it's not produced through this HIV estimates process that Mary described, which has meant weaker ownership and data use about key population data by national HIV programs or been a contributor to that. So one of the priorities for the UNAIDS reference group over this 5-year period has been strengthening this process. We're just wrapping up phase 1 of this process, which has involved collating existing key population data, collating, extracting, and validating data from existing survey databases, and then developing a workbook process through which national HIV teams are reviewing and triangulating data and comparing with existing model estimates to increase the robustness of the data that are available. And the second phase that we're embarking on now is conceiving a new model-based tool to synthesize key population data and produce national estimates, which will then feed into planning and global reporting, similar to the other components of the estimates that Mary described. And we envision this being similarly a tool that's usable by national HIV estimates teams who currently use the spectrum model. Key populations are, of course, not the only dimension of risk or vulnerability that are important. The global AIDS strategy has really implored us to stratify our HIV programs according to different needs and different risks of populations. And so here's another example of spatial modeling work that's been incorporated to look at the stratification of, for example, the adolescent girl and young woman population across different risk groups to help guide stratified prevention planning across districts within countries. And lastly, the important feature of models going forward are the ability to transition what data we're using to understand the epidemic as we transition from a period when HIV programs were very rapidly scaling up and we needed models to help us monitor very large programmatic changes to now monitoring sustaining progress. And this is a really nice figure that I've taken from the PEPFAR COP guidance that I think many people will be familiar with, that I think really shows us how much the situation has changed as we move from this rapid scale up that we've seen over the past decade to the increasingly small margins that we have in terms of untreated populations or new HIV infections over the next decade. And we need to monitor that we're effectively continuing to close those gaps. I think fundamentally that leaves us with a really key challenge from a surveillance perspective, which is that as these margins get smaller, they become harder to measure. And we have this increased availability and reliance on individual level routine health system data for surveillance, But I think we're all familiar with what these data look like, and sometimes the reporting challenges. And so we're increasingly going to be asking questions: are these data ready to use in the way that we would like them to use? And what are the gaps in the data and the things that we're missing by relying on data that are only collected through the health system? So what we envision happening is that we won't be able to entirely switch to using routine data, but it will be really important to continue purposive surveillance, but oriented around surveillance activities that help us to realize the value of routine data for monitoring trends and dynamics. And this is going to fill a couple of purposes. Firstly, our surveillance will help us to ensure the robustness and drive quality improvement of routine data. And secondly, surveillance will help us to complete the surveillance gaps, to assess the representativeness of our routine data, identify what populations are being missed, and help fill in that information about what determinants and inequities are in ongoing HIV transmission and prevention. And so in general, we expect to see a transition where we move from less kind of monolithic surveys to timely, targeted, and integrated surveys that are more integrated with program and strategic information. And some of the HIV surveillance priorities towards 2030, probably the top priority for the next year is to reconstitute routine ANC surveillance. We need more granular data about pregnant women for monitoring the epidemic overall than what we're getting right now from aggregate reporting. So we're really encouraging all countries to immediately start doing prospective recording of individual level ANC data from a representative sample of facilities. We also need more information about the context around people who are being newly diagnosed with HIV. So getting better surveillance data from at least a sample of individuals about HIV testing, treatment, and prevention history to understand where new infections are coming from or where interruptions in treatment are coming from. Thirdly, we need to drive improvement at monitoring ART program outcomes. As Mary mentioned, our current estimates of AIDS deaths are in sub-Saharan Africa are essentially an entirely modeled outcome. We have very little actual outcome data informing that, and that's going to be a priority as we want to actually monitor AIDS deaths continuing to decline. And fourth, we're going to continue to need household surveys, but change the way that we conceptualize them such that they're more targeted to fill gaps and address uncertainties arising from routine health system data. And really integrating our surveys with our health system data is going to be the way to unlock that. Thanks, I'm happy for questions and discussion. And if you'd like to find out more information about the work of the UNAIDS Reference Group on Estimates, Modeling, and Projections, the website is www.epidem.org.
Thank you. Jeff, I think it's me to go next now.
Yes, go ahead, Wilford.
Okay, thank you. Thank you, and thank you for availing us this opportunity to come and share our experience with spectrum model estimates in Uganda. Let's go to the next slide. My name is Wilford Kirungi, and I was introduced at the beginning. Next slide. Yes. Now, as many of you might be aware, we have braved a very severe HIV epidemic in Uganda for nearly 35 years. I and my colleagues here, our task is to track the magnitude and dynamics of the HIV epidemic. But as has been made clear by other presenters, HIV epidemic is a little more complex. There is no one data source that provides all the information. So we triangulate data from various sources: HIV surveillance, initially sentinel site-based, later on routine program data. We also draw data from routine service delivery reported through the Health Management Information System. We conduct periodic population surveys. I think in Uganda we've had like 4. We're planning the 5th. We also add data from research, from monitoring and evaluation, and mathematical modeling, and triangulate all this data to put together a clear picture of the epidemic. Now, triangulation of data from all these sources with spectrum is one of the core ways we have been tracking the epidemic in Uganda, especially tracking those indicators that Mary indicated that cannot be very easily determined from a single data source. Now, in Uganda, we have a history of about 20 years of using spectrum each year producing estimates and using them to inform programs. The spectrum model, as has been clearly indicated, has evolved over time from the pre-ART era to the current versions now, where we have near universal ART coverage and more complex data requirements. Next slide. Next. Now, with Spectrum, we have been able to obtain annual estimates of program indicators that were listed before, annual estimates of new HIV infections, vertical infections, AIDS mortality. We have been able to track AIDS burden, number of people living with HIV, and other variables derived from, including rates derived from some of these denominators. But in addition to that, we now have very good trend observations dating back to several years, and we can describe the trends in practically all these indicators. We also, based on some assumptions, project into the future and look at the future course of new infections, mortality, or when we hope HIV epidemic control can be attained in Uganda. Now, most of these estimates, as it was indicated before, can be obtained in 5-year age groups, urban and rural residents, or by gender, and also wider age groups. We've also been working towards obtaining subnational estimates, initially regional estimates with Spectrum, but these days we're working more within the Naomi model, using the Spectrum file to generate district level estimates of these indicators, disaggregated by those covariates as I have indicated, and also the 90 cascades or 95 cascades, particularly tracking the first 90, which, as you all recall, without a survey is rather difficult to obtain. Next slide. Next. I think, are they slowing down? Okay, so how do we go about this process? Now, the process involves data, and this process has evolved over time, especially as data requirements have become more complex. But what it involves is that every year we have a country team that develops the estimates through a participatory process. Why we use the country team is to harmonize the various assumptions that go into the activity. We have an estimates working group that draws a representation from the government institutions like the ministry, the AIDS Commission, and Bureau of Statistics. We work with our colleagues from the United Nations agencies, the United States government agencies, CDC, USAID, and PEPFAR country office. We also work with some IPs, implementing partners. The process involves capacity building. We obtain the latest version of Spectrum. As John indicated there, these changed quite a lot. We also participate in a training workshop. Sometimes it's virtual, oftentimes physical. And throughout the activity, we obtain mentorship from UNAIDS, from Avenir Health, from Imperial College, and from the reference group. The process starts with compiling data inputs, and these range from service delivery statistics, surveillance statistics, survey statistics, if they're available at that time, as well as population statistics. We review this data to ensure that it's as complete as possible and is of good quality. We convene a workshop where we develop the estimates in an iterative workshop. And again, here we have different competencies, surveillance specialists, testing, treatment, PMTCT, and statisticians, and other specialists. We obtain the estimates and submit them to UNAIDS for review. We respond to the comments. And then when we have the approved files, we always obtain clearance from the government of Uganda before they can be submitted to UNAIDS for dissemination, and also internal dissemination within the country. We usually work along a tight timeline of ensuring that these estimates are available by February so that they can be used for various processes, including the PEPFAR country operations plan. Next slide. Next slide. Now we use the spectrum estimates for a wide range of purposes to describe the epidemic. We use the estimates to obtain national and subnational targets for various services, testing, treatment, and others, to estimate costs for provision of services, for resource allocation and resource mobilization, for quantification of medical and pharmaceutical supplies, for advocacy for the focus of various interventions and program evaluation. So in the next couple of slides, I will show a few examples of where the data we have for this year or the previous year being used. Let's go to the next slide. In the next slide, we are comparing HIV incidence estimates from the last FIA, or the last population HIV impact assessment survey that we conducted in 2020, 2021. And as you can see, estimates there disaggregated by gender and also by age group. And on the right-hand panel, estimates for the same year obtained from Spectrum. The main message is here that they are practically consistent. If you look at the adolescent women, adolescent girls and young women, this is the population group in both data sources that has a very disproportionate share of HIV incidence. And this kind of data coming from Spectrum, but also consistent with what the population statistics indicates, made a very good case, or makes a very good case for advocating for focus programs for adolescent girls and young women that we now have in place, supported by PEPFAR under the DREAMS initiative. But other partners have since then come on board, including the Global Fund, the United Nations agencies, including domestic resources that are now increasingly becoming available to address this disproportionate share of HIV incidence. Next slide. Another area where we've used HIV spectrum estimates is depicted in the slide on the right-hand side here, where we are showing the trajectory of new infections over the past 12 years or so, and mortality on the lower curve, and comparing that with the targets under the SDGs for 2020 and 2021. Now, we know Uganda has heavily invested in HIV treatment over the past decade, and we can see that arising from that, we have had a predictable sharp drop in AIDS-related mortality, not so much so the case in new infections. We nearly met the targets for mortality and may be on course to meet the 2030 targets for mortality reduction, but not so much with the new infections. And this information was used to make the case that we are not likely to treat ourselves out of the epidemic. We need to equally invest in HIV prevention interventions and bend that curve a little more. Next slide. The next slide. This is also coming from Spectrum, where we have trends in number of people living with HIV aged under 14. Oh, sorry. I'm sorry. The level is quite wrong. It should be 15 to 24, and those above 50 years. The burden of HIV borne by individuals, young people 15 to 24, is declining steadily. But in this place, we can see the burden borne by individuals aged over 50 is increasing substantially and projected to reach about 30% by 2030. We've used this information to advise our treatment programs to focus or to plan for treating older individuals who are likely to have comorbidities on an increasing basis as we go forward. Next slide. The next slide. This is the stacked bar analysis of pediatric infections or vertical infections that John presented ably there. Here, again, we have used this information to recommend programs to focus on the pervasive causes of vertical infections. We can see the proportion of women, a big number of women HIV-infected women are already on treatment, and another big number were diagnosed and started treatment. But if you look at the proportion, at the numbers of new infections arising from such women, they are out of proportion of their size. On the other hand, we have the majority of infections arising from few women that default from treatment, and those that acquire new HIV infections in the green, that reflect the main causes of vertical infections in Uganda. And our PMTCT programs are now increasingly focusing on these groups to strengthen retention among those started on treatment, but also reduce new infections among antenatal and breastfeeding women, including retesting, and also provision for PrEP among high-risk pregnant women. Again, largely informed by the analysis coming out of Spectrum data. Next slide. And then lastly, if you look at the trends of new HIV infections, all-cause mortality and age-related mortality, you can see that Uganda by 2022 was not anywhere close to attaining epidemic control that John described there. So projecting into the future, we worked out a package that we think would substantially bend the curve of new infections to fall under all-cause mortality, and we attain and sustain HIV epidemic control. Now, this is the information that we have fed to the programs to work around. Of course, it's not going to be very easy to bend that curve that sharply, but again, using Spectrum models and estimates, we are able to inform the programs, and quite a number of interventions are being planned with more ambitious targets to try to take us to that direction of attaining and sustaining HIV epidemic control. Next slide.
Hello, everyone. I'm your next speaker, Anna Burstein. It seems that we've lost Wilford.
And
We'll just give it one more minute to see if Wilford's connection is restored. Unfortunately, it looks like Wilford's connection was interrupted. But let's just see if he's able to come back. Oh, excellent. Wilford, we can see you again. Would you like to finish your presentation?
Are you able to unmute, Wilford?
well, sorry, the call dropped, but I think we had come to the end. We just end with the acknowledgements of all those institutions, and we have our team there in South Africa, I think in December last year, during the training. Thank you. I think the challenges, many of them had already been addressed by previous speakers. Thank you very much.
Thank you, Wilfred, and for everyone still hanging in with us for these extra long grand rounds, thank you for still being here. My name is Anna Berstein. I'm an assistant professor of population health at NYU Grossman School of Medicine, and I've been given the wonderful job of tying it all together today regarding approaches for triangulating data, for validating models, and what are the current capabilities and limitations. So the motivating question of this final talk really falls into three categories. First, having looked at one model in depth, the generation of the UNAIDS estimates, stepping back for a moment and asking, how do we know when we have a particular type of estimate or a particular question for a model, which type of model to use, considering the benefits and drawbacks of different model types? How do we find a good match for the question at hand? Second, once we've used that model, how do we know that its estimates are right? Does it do what we think it does in terms of the actual model code? Have the estimates been right before in the sense of the sort of validation that Mary and John have talked about today? And if we had multiple different models that all pass these validation checks, would the models agree with one another? And then finally, what do we do when data are unavailable or inconsistent or incorrect? How do we deal with uncertainty in inputs, creating uncertainty in outputs, and how do we triangulate data sources accounting for the mechanisms of the disease we're modeling? Next slide, please. So just at a very high level, the model that we've heard about today is what we would call a compartmental model, meaning that it's going to track different types of people, different categories of people. In the diagram here, we have blue, red, and green, so that could be uninfected, infected, and treated people, for example. Tracking just the numbers of people in categories is a less computationally intensive approach. It's relatively easy to code an initial model. And that's part of why this model has been in the hands of people all around the world for so long, in order, the same model that produces the UNAIDS estimates. But it is more difficult with a model like this to add new attributes. So for example, if we needed these three categories by sex, male and female, instead of 3 groups, we would have 6. If we also needed it stratified into 2 locations, it would go from 6 to 12. If we also needed it in 10 age groups, it would go from 12 to 120, and so on, with the complexity growing exponentially. An alternative approach is what's called agent-based modeling, where in the model code, you actually represent every individual person. So here, each dot can be blue, red, or green. And this is more computationally intensive to simulate. It's harder to get a model like this on laptops all over the world. It's also harder to code the initial model, but an advantage is that it's easier to add new attributes. So if we wanted to give each little circle a hat of a particular color, and then we also wanted to add an earring, and then we also wanted to add a second earring, each of those little bells and whistles only increases the complexity linearly rather than exponentially. Next slide. So compartmental models, like the ones that we've been hearing about today, can also be grouped into 2 types: stochastic versus deterministic. A stochastic model has randomness in it, which gives a slightly different answer every time you run a model like that. So it needs to be run more times, which means more computationally intensive. However, it is useful to represent uncertainty in projections due to small numbers. So for example, when a disease is just emerging and the difference between one case and no cases in a location is a real question, or near the elimination of a disease where you have that question again. Versus a deterministic model assumes that populations are very large. So you can think of a faucet, that's turned on at such a low flow that you can count the drops of water. When it's turned on at a sufficiently high flow, you don't need to count drops of water anymore. There's so much water coming out. And so it's applicable when a disease is highly endemic, as HIV/AIDS is in many parts of the world. And it's less computationally intensive and easier to code, which again means the model can quickly get into the hands of many people all around the world. And so speaking of spectrum, today we've seen one model that is a deterministic compartmental model, and I'd like to talk a little bit about the opposite end of the spectrum, a relatively complex stochastic agent-based model. Next slide. So in agent-based models as well, we can think about models which assume that transmission happens group to group. So similarly to a compartmental model, to find out how many new infections there will be, you take the number of people who are susceptible to infection, multiplied by the number of people who are infectious. And then you can modify that by different things like the use of HIV prevention, for example, versus the other way to do that at the opposite end of the extreme is a network model. And this really requires an agent-based model where you would look at each person and their position in the social network. And it really is a lifelike model where people would infect those around them in their social network. And not only is this in some ways more lifelike, it's also necessary to represent certain types of interventions. For example, contact tracing is quite difficult to model without looking at a network. Next slide. So just to give one particular example, a model which we use quite a bit at NYU, known as EMOD HIV, is an agent-based model. It's a network model, so it's really at the more complicated end of the spectrum. It's developed by a group of software developers that continue to maintain it at the Institute for Disease Modeling, which is part of the Bill and Melinda Gates Foundation. And they are really rigorous about validating the software code of this model. There are over 600 software tests, about over 140 particular tests of scientific features in the model, like the natural history of disease and so forth. And additionally, this model is built into a larger code base known as EMOD, which actually models, as you can see here, a number of different diseases: polio, typhoid, dengue, malaria, tuberculosis. And because of that, many different researchers use that same code, which also helps with validating the code, because many people have run it and touched it and made sure that it works as expected. Our particular group focuses on HIV in sub-Saharan Africa, and in particular in the 6 countries listed here. And the key components of the model that allow us to work in those countries are the demographics, which are in many ways similar to the demographics that John Stover described in the UNAIDS spectrum model. The transmission network, like I mentioned, which is a unique ability of agent-based models. An HIV care continuum, and then the natural history of disease progression, and then the effect of HIV treatment. Next slide. So some of the examples of our current research and the reason why we needed a model like ours to do this research are shown here. At the top is an example of some recent work that we did evaluating the cost effectiveness of a dual prevention pill that co-formulates oral contraception with HIV PrEP. And we looked at this in 3 different countries and different user populations, and users who would alternatively have used a variety of other products if this product were not available. And so the main reason why we used an agent-based model here was because, as I mentioned, new attributes in a model don't add complexity in an exponential way. So adding more complexity, more bells and whistles is more feasible in a model like this. So when we had to add, differential risks of pregnancy and different outcomes of unintended pregnancy, we were able to do that building on this model that we already had. Another project looking at the impact of mental health on HIV care and prevention is a very similar story where we need to now add mental health attributes to the population. Another project that we're doing focusing in Zambia is looking at HIV recency testing as a way to guide precision public health. So in a real-time way, doing outbreak response in response to real-time recency testing. And in that case, we actually needed the network component of the model in particular, which allows us to look at network-based interventions like index testing and contact tracing. Another project is looking at HIV epidemic aging and the effects of cardiovascular disease and diabetes. And in that case, there are a couple of different things. There's the complexity issue, and then also looking at the network age structure and the way that people are expected to age with HIV as their partners age with HIV. And then finally, multi-model comparisons. There are not so many agent-based network models out there in the world. And so it's useful as part of a comparison, and we frequently do this with John's team, to have models with very different structures, all ask the same question and see if the answer is the same. And it can be very, very reassuring, as Mary, I'm sure, would tell you, when the same policy question gets the same answer from models that are built in very different ways. It adds confidence to that policy choice. Next slide, please. So how do we know if model estimates are right? We've heard the word validation a few times today, but really it can mean different things. I think one of the first and most basic questions to ask is, the model code says it's supposed to do this, but does it actually do that? Because software code can have errors. I mentioned that with our model, we have a large suite of hundreds of tests, and these are run routinely anytime the model code is modified. And these tend to be small contrived scenarios, like, well, what happens if we just put everybody on treatment, or put nobody on treatment, or infect this particular group in the model, and just observe in the model code what is the behavior, and is that behavior what we would expect given how the model was built. Another question is the model able to fit what we've observed so far of the AIDS epidemic? And that can be helpful. That's often referred to as model calibration, because we make an effort to fit those data. But some models can and some models can't fit the data. And if they can, that's reassuring. It means they're designed so that they can recapitulate the epidemic dynamics. A third question is, do the model results comport with observations that were not included in calibrating or fitting the model? So if I told you, hey, there's this study that happened, or hey, this survey was not part of the model's calibration, was your model fitting the data from that survey? And that's something that we refer to as retrospective validation, going back and saying this data that was held out from calibration, does it still comport with what the model was predicting back then? But a bit like a randomized trial, it's always a little unnerving when that happens, because you'd like it to be blinded, so to speak. You would like to really be sure that the investigators using the model really were unaware of the data, or even an inkling of what the data might be at the time that the prediction was made. And for that reason, the most rigorous form of validation that modelers strive for, although there are not always opportunities to do it, is prospective validation. And that's when models make a guess about what epidemic trends might happen in the future while they're still unaware of those results. These can be very time-intensive activities, because often we wait years to get the results of something like a clinical trial or a FIA survey, but it can really add confidence in terms of the validity of the model prediction. Next slide. So I just want to give one example of prospective validation that our team was able to do, and that was in collaboration with the SEARCH trial team. So that was a trial that was one of the 4 major test and treat trials to look at the effect of scaling up treatment on community level incidents. And this trial in particular was conducted in Western Kenya and then in Eastern and Southwestern Uganda, totaling 32 different communities. Next slide. The principle of this trial was that half of the communities would receive expanded HIV testing through annual health fairs and support to link and stay on treatment. However, the trial did have some complexities in terms of evaluating this question. First of all, the trial had quite an active control arm. All of the control communities at baseline also received universal testing. And so it wasn't a control in the sense of a completely unmodified community. And secondly, there is in and out migration from these communities. So there was a possibility of contamination or spill from outside of the intervention community to inside of the community. Next slide. So one of the first things that we did in order to use to perform prospective validation with this study is just simplify things a little bit. So here, what we did was we grouped these 32 different communities into 3 clusters, largely by HIV prevalence, but we found that they also clustered on other attributes, such as the use of traditional male circumcision, which turned out to correlate with prevalence, as you would expect. The age distribution, actually the proportion of the population under 15, and then also the extent to which people migrate in and out of the community. Next slide. And so for those 3 clusters, so grouped together communities, we fit our model to the baseline observations of this study, which were primarily HIV prevalence. So there's female prevalence on the top and male prevalence on the bottom for the clusters. And then next slide, we also looked at the data by age. So we fit our model to also match the age distribution of HIV prevalence. And so that was what we did when the trial was just getting started. And then we made a prediction. What might incidence look like 3 years later at the conclusion of this trial in the control arm and in the intervention communities? And we actually made 4 different projections. First, we looked at a prediction of incidence in an ideal trial where everybody stays in the community and where there's no active control. So the control has actually never been perturbed or changed by the study being there. And that's the top left box there. We predicted that there would be a 47% reduction in HIV incidence due to the intervention. And then we added in the fact of the active control, that there had been baseline testing for everyone in the control communities. And then also the fact that people migrate in and out of the community. So even if you were to shut down transmission, people could bring HIV in from outside of the intervention area. And then finally, both of those at the same time, the fact of the active control and the migration in and out. And when you have both of those at the same time, we found that the observed incidence would only be about 4% lower on average in the intervention and control communities. And you can see that these distributions are overlapping, that there would not be power to tell the difference. And then sure enough, when this trial was unblinded, we found there was not a significant difference. We found that the incidence we predicted matched the observed incidence in the trial. And in addition to this trial helping us to validate the ability of our model to predict HIV incidence, we were also able to help the study because we were able to say, if there had been a true control and no in and out migration, in other words, if this intervention were implemented everywhere, this is a prediction of what the impact would have been, and it would have been significant at 47%. So it also helped to interpret the result of the trial. Next slide, please. Now, I do want to comment that not all failed validation means that the model is bad and should be thrown away. Sometimes failed validation is valuable. And so here's an example of, this is actually work led by our own Jeff Eaton, of an incorrect prediction from 8 different models of a survey in South Africa, a population-based survey, where incidence was estimated using recency testing. And every single model underpredicted women's HIV incidence in particular, despite being more or less correct in other parameters. And what this did was it encouraged the modeling community. We were convened through the HIV Modeling Consortium to talk together and revisit our assumptions. And in the case of my own group, we realized that we had incorrect assumptions in the model about the sex difference in the number on treatment, where in our model, we were not accounting for just how much treatment was skewed toward women, which meant that the incidence benefit of treatment was skewed more toward men. And so women were not benefiting as much at this point in history from treatment as prevention. And so that helped us to correct our model, and it's improved our estimates ever since. Next slide. So just to summarize here, I hope from this you'll take away that different modeling methods can have distinct purposes and advantages and disadvantages, from deterministic compartmental models, which we've spent most of our time on today, which can be most readily coded, tested, and can be run often on a laptop and put in the hands of many people, to stochastic compartmental models, to agent-based models, including ones with a network such as ours, which can be suitable for certain types of questions such as contact tracing. I hope that you appreciate that model validation can occur at multiple levels, from making sure the model code is working correctly, to calibration and retrospective validation based on what we already know, and then to the more ambitious undertaking of prospective validation to test the predictive capabilities. And finally, that failed validation is not necessarily a failure. It can stimulate triangulation, and it can assist with understanding which data are missing from models, are biased or incorrect, or which assumptions or inputs to models are incorrect, so we can keep improving our estimate. So I'll end here with thanks from many people who've contributed to this model development. And I have one last slide just acknowledging all the organizations that have contributed to this particular model, EMOD HIV, all around the world. Big thanks to everyone for sticking with us for this very long grand rounds, and thank you for listening.
Thank you, Anna, Wilford, Jeff, John, and Mary for this fabulous presentation today. We've really enjoyed it. And thank you to all of our participants who stuck with us for the extra long and rounds and for going over. I apologize, we won't have time for any live questions today, but the webinar recordings and the slides will be posted on the ICAP website. We'll also send an email blast when everything's ready. So if you want to review everything that we learned today, it'll be available to you. Thank you all so much for joining us and have a great rest of your day. Thank you.